Thank you very much. I'd like to start by acknowledging the traditional owners of the land, the Wurundjeri people of the Kulin Nation. And this part of Melbourne, as you may or may not know, it used to be a traditional meeting place of the Kulin Nation. It was a hill, known as Eastern Hill, as it is now, and is where the Aboriginal people came together. But it's also interesting to reflect that whenever anybody has done a study of the quality of care provided to Aboriginal people, they've always found that the outcomes are worse than for non-Indigenous Australians. So it's, I hope you, as you hear of that and you hear of those acknowledgements of country, you think about the consequences of all of that. And if all goes well, I should be able to get that to move, but maybe all doesn't go well. This is a system error, as you would appreciate. So I'll be talking about the Targeting Zero report, and you may know some of the story, but it was stimulated by a quality scandal at Djerriwarrh Health by Bacchus Marsh Hospital. There'd been a number of previous reviews by the Auditor General. This one said there ought to be an incident reporting system. This next one said there ought to be an incident reporting system. This next one said there ought to be an incident reporting system that works, because they'd actually put in an incident reporting system, but it was actually an incident recording system, and nothing actually came out of the system, and that was apparently some sort of failure. But in the case of Bacchus Marsh, there'd been an independent review by the Commission on Safety and Quality in Healthcare. And this terrible slide is an excerpt of that review. That review looked at the question of, once the Health Department knew about the terrible events at Bacchus Marsh, did they do the right thing? And the report basically said, by and large, they did the right thing. Of course, the question was, should they have known earlier? But this one tells you that there was a whistleblower in many of these events. There is always a whistleblower, either staff or patient. Of course, this time it was the union, the Australian Nursing and Midwifery Federation. They reported it to the department. The department centrally, there was a maternity and newborn children's network at the time, and they said, look, deaths of babies is not actually an issue for maternity and newborn clinical network. Rather, you should talk to the hospital. They then spoke to the chief executive of the hospital, who said, look, a cluster of deaths of baby is not an issue for the chief executive of the hospital. It's actually a responsibility of the Director of Nursing and Midwifery. So the Health Department Regional Office rang the Director of Nursing and Midwifery, and she said that, look, don't you worry about this, everything's okay. And then they said, well, of course, if someone tells us everything's okay, it must be okay. So that was the department's involvement. So in the face of reassurances that the concerns raised by the ANMF were being addressed by the Health Service, the department took no further action. Now, there may be some redeeming features in all that behaviour, but it's not apparent to me. So, but it's also interesting how the department, the signals the department sent to health services about what mattered. And very much at the time, there was a feeling that the only thing that mattered in monitoring of health services was financial performance. But in fact, that's not true. The department's scoring system had essentially three major components. The first one, patient experience and outcomes, governance, leadership and culture, including the Safety Culture Index, safety and quality measured by two things, hand hygiene and immunisation. That added to 60% of the, that added to 40% of the weight for the performance scoring system, with financial sustainability at 30% and access, such as waiting times, at 30%. So the plurality, the major single one was the quality and safety dimensions. And when I met with the people in the department as part of this review, they were quite proud because they had increased the relative weight from 15% to 40% just quite recently. Now, one of the things I do when I undertake reviews is go and spend time in the pub. And there's a way of gathering information only, not for any other purpose. And I ask people, is it a good idea that if you do better on finance, it's okay to do worse on quality? And despite copious amounts of meetings in the pubs, I could not find a single Victorian who thought it was a good idea that you should be able to trade off finance and quality in that way. So the other issue is, what does good look like? With finance, we know what good looks like. Good means coming in on budget. We know with waiting times what good looks like. Good means low waiting times. What does good look like with quality and safety? I was listening to Norman Swan this morning, as I was walking here this morning, about the terrible stories in the UK about system errors and so on, and reflection. And good in quality and safety terms means learning from mistakes, not necessarily covering them up or trying to have a low score. And so what we saw at Bacchus Marsh was a failure of culture. And this is a lovely quote, or what I think is a lovely quote, but basically the only thing of real importance that leaders do is create and manage the culture. And this is what we are trying to address, the culture of the health department in particular, in trying to change its focus on safety and quality. Here's an excerpt from the Health Services Act. When we did the review, only applied to larger hospitals. The Act has now been amended, and exactly the same duty applies to smaller hospitals. And so it basically, the board has a clear responsibility to oversight and monitor and improve the quality and effectiveness of services. And what went wrong in Bacchus Marsh? This is the so-called Swiss cheese diagram, which has multiple interpretations. But there was a question about, did the board have the right skills? Bacchus Marsh Hospital was just about to be accredited when these events were found. It was accredited for the entire period that we're talking about. The accreditation system obviously wasn't working properly. Dysfunctional incident reporting system, dysfunctional safety monitoring system in the health department and in the health service, and of course this focus on finance. So the department at the time talked about devolved governance being the big thing, but we recognised there were other functions that needed to be improved, including strengthening boards. At the time, boards were just simply asked, a board applicant, do you have clinical governance skills? And they said yes or no. The majority of the Djerriwarrh Health Service Board said they had clinical governance skills. Who knows what they thought they were ticking when they ticked that. But we suggested you need to be a bit more nuanced. I stole this idea from RMIT, where I'm on the council, and which is that they ought to be graded rather than just 0-1, having 0 meaning nothing through to a 5, which means you've actually got some really serious skills in this area. And when I spoke to the Chancellor and said Ziggy Swistowski, that I'd stolen this from RMIT, he said that's all right. He stole it from Suncorp, where he was also chair of the board. So we need to improve the boards. We need to have better reporting, and I think Ewan will talk about that because they're making great strides in that. We need to have better information available, including leading indicators. This is a graph from a study done by colleagues at the University of Melbourne, where they trawled through all of the complaints made to complaints authorities, patient complaints authorities across Australia. And what they found, which isn't surprising if you think about it, was that if you've had 10 complaints against you in the past decade, the chance of another complaint in the next year is almost 100%. If you've had only 1 complaint against you in the last decade, the chance of another complaint in the next year is 10%. So we can actually know who the clinicians, the individual clinicians who seem to attract complaints. The question is, who ought to know that? Should the clinician against whom all those complaints being made be the only person in the health system that has an oversight of that? Should the complaints authorities collate all that information? Should the Health Service Board or the Registration Authority know about this cluster of complaints? Because I think that is a leading indicator of problems. We argued in that report and in the report we released last week that there needs to be better use of the routine data, basically because we think that we've seen a transition occurring in the health system, and I'll come back to this. This is what we actually said in our report, the department make better use of data, and there also be a stronger obligation for clinical registries to report that data so that things can be done about it, not just collected in a bowerbird way. I'll just skip through that too, which essentially says the same sort of thing. This is again, this group at the University of Melbourne asked boards of health services in Victoria how their health service stood. The good news is that about 75% of board members said their health service has better or much better quality than the average Victorian hospital, and a further 20% said it was about the same. So 95% of hospitals in Victoria are functioning above average, which is really very heartening, especially for those of us who have a consultancy in arithmetic. But what we're signalling in that report, the Targeting Zero report, and in the report that we did we released last week, is that we're beginning to see a change of paradigm. That in the olden days, adverse events were an issue for bad apples. It was secret doctors' business, that the doctors sat in a secret huddle and met as consenting adults to discuss the adverse event and looked at a particular incident, often associated with blame. Over time, we realised that adverse events were associated with system errors, and so in that early period, what became important politically and policy-wise was protecting that the integrity of those systems, including giving legal indemnity and protection. And then we had the emphasis on system errors, an increase in looking using incident reporting systems, nurses doing analysis of what's happening. Then we suddenly started to realise that there was patterns of adverse events occurring, what I call here in this slide the epidemiology of outcomes. So rather than focusing on individual outcomes, focusing on the pattern of outcomes. And the fourth shift that's now occurring is that we're moving from a system where quality and safety is a systems issue to where quality and safety is a payer issue, and starting to talk about financial incentives for better or worse. And so we're seeing this shift, and here's some examples of looking at patterns of adverse events to see where there's been a change in the patterns and where you might start to investigate. In our Targeting Zero report, we published information here about all complications that are occurring in Victorian hospitals. In our report last week, we showed that about 25% of all admissions have something go wrong, whether it's something minor, whether it's something major, something goes wrong. And what's more interesting is there's huge variation across the country in that. This is the list of so-called hospital-acquired complications, which is the designated list produced by the Commission on Safety and Quality in Healthcare. Much smaller incidence of complications in that list. This list, I think, is quite problematic for a whole host of reasons, partly because the governments, in their wisdom, have labelled everything on this list as preventable, although the Commission, in its wisdom, has labelled on its website that they're not preventable. So we've got a government authority saying they're not preventable and the government minister saying they are, but that's interesting in and of itself. And this list, the hospital-acquired complications list, is now, in a very peculiar way, being used, allegedly used for financial incentives come the 1st of July of this year. So we suggested that we need to change the governance. We need to publish that sort of information, not necessarily because the consumers will use it, but the consumers are actually very interested in this, very interested in knowing about complications. But the evidence from the US is that they actually don't use it to choose what health services they go to. But we recommended in Targeting Zero, and again in our report we released last week, that we should publish this information. We also suggested the accreditation system is probably not fit for purpose. Here's an example. There's a set of national standards. The national standards are actually quite good. They have a standard about infection control, for example, but the accreditation process doesn't look at the data about hospital-acquired infections when they're doing the inspections. And so the accreditation process has actually turned into an event where a host of people descend on a hospital and produce a report, rather than focusing on the epidemiology of outcomes, rather than saying this hospital is going great guns on hospital-acquired infections, we don't need to look at that standard, the outcomes speak for themselves, or this hospital is going terribly on hospital-acquired infections, we're going to have an inspection tomorrow to find out about what's going on. So moving from an event focus to a risk-based outcome focus is something we need to be turning our minds to. Of course, I have to declare a conflict of interest because the accreditation system is actually quite good for me because I do have shares in Qantas. It may have benefits for other things as well, of course. We need to be understanding a bit more about performance. This is the typical way health departments look at performance. This is from England. I chose it especially because it's a developing country. Ewan knows how terrible off the English are. But what we have here is the cost for a hip replacement in England. You've got one hospital on the extreme left, which costs about £8,000 more than the England average, and a hospital on the extreme right, which costs about £5,000 less than the England average. But in England, they ask patients who are having hip replacement to report on their outcomes before and after, their pain levels, and so on. And you can see in this graph, the dark box represents the pre-surgery outcomes, or patient-reported outcomes for hips and knee replacements and so on, and the grey, the post-surgery, and you can see a significant improvement on average in those scores. And of course, you can then you can ask the patients to do their own scores, and you can tell the patients about it, but I'll skip that. But this is what I want to get to, which is this is the same graph in terms of cost, and so the vertical axis now is the £8,000 more expensive hospital on the top left-hand dot there, and the £6,000 or £5,000 cheaper than the England average on the bottom axis. So we've got the vertical axis is the cost axis, and the horizontal axis is the Oxford Hip Score measure. And you can see there are some hospitals here, such as Blackpool Hospital, which Blackpool may have some redeeming features, which is unknown to anybody, but it's also the hospital may have some redeeming features, but certainly not in the care of people who are having a hip replacement, because they're both more expensive and worse outcomes than the England average. But you also have hospitals which have better outcomes than the England average and are cheaper than the England average. So we need to actually bring together in our mind at the same time the issue of quality and cost, and there's no evidence, for example, in this graph, that improved quality is associated with increased cost, or in fact that lower cost is associated with lower quality. I'll skip the issue of, well, we looked at an issue of volume outcome relationships. This was for Whipple's procedure, and you can see there is a significant volume outcome relationship, higher volumes associated with better outcomes. There's a huge debate in the international literature about where the threshold is. Is there a threshold? The answer in the international literature is you should be doing at least 10. Some people say at least 54 of these procedures a year if you want to be good quality. And this is the lowest international threshold is that 10 point. And of course, you've got a number of Victorian hospitals, public and private, which are doing substantially less than 10. And the question, of course, is that might be fine, but do they tell their patients, for example, if you front up at Public Hospital L, do they say, look, you're about to have a Whipple's procedure. The good news is you're the first one we've done in the last couple of years, so you are unique. And we're not going to tell you, of course, that being unique means your outcomes are going to be so much poorer than if you're not unique. Incidentally, of those hospitals which do fewer than 10, only 4 of them are rural. So this is not an issue about rural-urban. This is an issue about what's happening in metropolitan Melbourne. Anyway, so the whole issue is what's the jobs of clinicians, what's the jobs of clinical leaders, what's the job of the CEO. Clinicians' job, of course, is the hardest. They're the ones that are right at the front line, and they have to know what the clinical practice will minimise the adverse event rate or the complication rate and implement that well. Everybody else is about trying to detect if those things go wrong, trying to detect what's happening using, as I've argued, the epidemiology of outcomes, using the information we've got. So we made a series of recommendations in our report. The government accepted all of those recommendations in principle. They're now being implemented, and Ewan will tell you a bit more about that. Of course, one of the questions is, when do you start evaluating how well the implementation is going? And my view is not now. In fact, my view is you need to wait a couple of years, because changing a system the size of the health system in Victoria takes a bit of time, and the important thing is starting on that journey and getting it right. And of course, I would thank the people who were involved in the review with me: Harvey Newnham, clinician at the Alfred, Marie Cudahy, CEO at Kyneton Health, and Jonathan Prescott, who was the person from the health department seconded to work with me on the review, is somewhere here in the room. So thank you very much.